the National Rural Health Association is here. Brock currently serves as the Senior Vice President of Member Services for the National Rural Health Association. It's a membership organization with over 21,000 members nationwide. Mr. Slabach has over 22 years of experience in the administration of rural hospitals. From 1987 through 2007, he was the administrator of the Field Memorial Community Hospital in Centerville, Mississippi, and he earned his Bachelor of Science from Oklahoma Baptist University and his Master of Public Health in Health Administration from the University of Oklahoma. So welcome, Brock, and thank you.
Oh, thank you, Jessica, and thanks to you all for the opportunity to present this afternoon on this webinar presentation. I want to thank John Barnes and his work in Michigan at the Office for Rural Health and extending to me also the invitation to this session this afternoon. John serves on our Board of Trustees representing the State Office Council, and it's just a pleasure to be able to participate this afternoon. The National Rural Health Association is a membership organization, as Jessica said. We serve 62 million people who call rural America home. I will say at the outset that we are nonprofit and nonpartisan. So as a nonprofit, nonpartisan organization, I'll talk a little bit about that as we go forward in terms of what that means on the Affordable Care Act. We do value our members, and if anyone is on the line and would like to become a member, you can go to ruralhealthweb.org and join NRHA. We also have started a foundation, which there is information on the front page of our website about that. This is a foundation that's a nonprofit tax-deductible organization so that we can perpetuate rural leaders in our communities so that the next generation can be adequately trained and resourced for their leadership capacity. We do conduct a lot of meetings throughout the year, and the Multiracial, Multicultural Conference is coming up in San Antonio in December. The Policy Institute, which is our major Washington meeting, is going to be February 4 to 6, and we would certainly welcome anyone interested in that to come over to D.C. For those 2 or 3 days of information and advocacy on behalf of rural issues. Our annual conference, our big tent conference, is going to be in Las Vegas in April 22 to 25, and then Quality Clinical for next year will be in Atlanta, Georgia in July, and then last but not least is our Rural Health Clinic Critical Access Hospital meeting, which will be held in Kansas City September 30 to October 3rd, 2014. So, to begin with, I wanted to stress that we are a grassroots organization. We don't have a political action committee. We depend solely on the advocacy of folks like yourselves on the line today. We'd like to think it's the power of our arguments that really make the day. We don't have money to grease the skids to make things work, as Washington typically these days seems to be in that mode. We are very successful, though, in putting forward ideas that have merit and hopefully getting folks to take us up on that. So that's why we like for you all to call your senators, your congressmen and women to be able to explain to them the problems that we have in rural communities and why it is that we need to be aware of the impacts of policy at a national level on local communities in terms of health care. So the agenda today, I'm going to try to keep my comments within 45 minutes, and then if there's any questions that come up, please text those in, as Jessica said, there in the chat tool on the lower left side, I guess, of your screen. And Jessica will be monitoring those as we go forward, and we will either save some of them up for the end, or she can interrupt me and we can deal with it at the time. But I do want this to be as interactive as possible, especially at the end. So the budget is what I'll talk about first, the federal budget, which is incredibly important to the operation of many of our rural facilities. And then what does the Affordable Care Act mean for rural communities particularly, and what will be some of the struggles and problems that we'll be seeing over the next several months in the rollout of that program. So we just got through with the shutdown, showdown. That was the event that happened in the first 16 days, basically, of October. Essentially, the two houses of Congress couldn't come together to agree on a continuing resolution before the midnight of September 30, and so they had to then shut the government down since there was no authorizing legislation to run non-emergency sections of the operation. So late on October 16, the President signed the law which raised the debt ceiling until February 7th, and then the continuing resolution will extend until January 15th, which is the concurrent resolution that the government's operating under. The CR that was passed, as we call it, the continuing resolution that was passed, is going to require a budget conference committee, which is composed of members of the House and Senate budget committees, to come together and report a proposal by December 13th, which is now barely just a little over a month away. I don't know that if anybody has been watching Congress for very long, I don't think that anyone's really hopeful that they're going to come up with anything really substantive by December 13th. I mean, it's very possible, but it may be that by January 15th, we will once again be in a similar situation that we were in coming up to a deadline that we won't have any resolution for. So we'll see what the mood is in Congress as to whether we'll enter into another period of shutdown after January 15. It's unlikely, though, that further efforts to derail the Affordable Care Act or the ACA will succeed prior to the January 1st, 2014 effective date. So this was one of the major holdups, if you will, for the continuing resolution that passed on October 16, that the certain elements, particularly in the House, representatives wanted to use the continuing resolution as leverage, if you will, to either delay or completely repeal the Affordable Care Act before its implementation in January. So one of the things that came out, I wanted to focus on this on the call today. One of the things that came out of the continuing resolution, the budget committee, the conference committee that is meeting currently and is supposed to report their work by December 15th, one of the things that they developed was a proposed permanent fix to the sustainable growth rate. For those of you that may not be aware, back in 2003, there was a formula put into place that was to maintain or cap the cost of the physician fee schedule payments that were being paid every year. And this formula is particularly interesting because it set forward a way to keep the increase in those expenditures from growing too fast. And so every year since then, a moratorium has been placed on the implementation of the sustainable growth rate formulas. And so we're now getting to another deadline in December of 31 of this year. The moratorium on the sustainable growth rate for physician fee schedules will expire, just like it has over the last 10 years. And the conference committee that I talked about just a second ago is trying to come up with a way to permanently fix this problem so that we don't come up to the end of every year requesting this extension of the moratorium. Well, in order to accomplish that, which is quite an expensive fix, it's about $130 billion over 10 years, which even in government terms, that's a lot of money, freeze the physician fee schedule rates for the next 10 years. So it would essentially lock in what a physician is being paid under the fee schedule under Part B for the next 10 years. And then future increases for physicians, those increases that physicians would get as part of the annual update, would only be dependent upon quality reporting programs. So if you're a physician in a rural community and you're not participating in maybe some of the quality reporting systems that are in place for physician practices, you may go for a period of time without ever receiving any increases, is the way the proposal is being stated right now. The biggest concern that we have at National Rural Health Association, of course, is that the pay-fors, this is the concept that for every dollar of increase in spending has to be matched in a dollar of decrease someplace else. There's not been pay-fors identified for the offsetting of the $130 billion or so dollars of cost that the SGR fix would include. So we are very concerned and would oppose any effort that would use some of our hospital programs, some of our payment programs to rural facilities as a pay-for to fix permanently this sustainable growth rate problem. So it puts us in a very difficult position because obviously we are very interested and very much in favor of fixing the sustainable growth rate problem. It's just that we don't want to do it at the expense of other rural providers such as rural hospitals or rural health clinics or federally qualified health centers in rural communities. We don't want to see decreases in those funding streams in order to accomplish the sustainable growth rate fix. So that's what we're working on now between the end of the year, which is a pretty big lift for us to be able to effectively manage this kind of system that we're on right now, this transition. So the Affordable Care Act in rural America. So it's one of those things that offers great promise, and also with any promise, with any opportunity comes some downsides. And I want to talk a little bit about both sides of this and maybe provide some information about the Affordable Care Act that may not be so well known in the general public. First of all, the Affordable Care Act was signed into law in March of 2010. It's a large bill. It has 9 titles with over 2,000 pages, and it affects many sectors of the healthcare economy. I will say that one of the things that has been difficult for us in association work, and certainly for members that are dealing with the day-to-day barrage of regulations that are being released, not only from Health and Human Services, but from the Department of Defense, the Veterans Administration, the Indian Health Service, and the IRS has released tens of thousands of pages of regulations which are required to implement this law, much of which has to be in before January 1st of this year. So what does the ACA do? And many of you probably know this already, so I'll just quickly cover this. But it covers incrementally 10% more of the population through subsidies, or possibly subsidies. Some people may not be eligible because they earn more than 400% of the federal poverty level. The other thing it does is it sets up a modified community rating system so that if you're an individual going to the insurance market, you will now be placed into a product rating that will include the entire community, not just that individual. It also excludes pre-existing exclusions. It presents guaranteed issue, meaning no matter what some of your pre-existing conditions could be, you are guaranteed issue of a policy. And it expands dependent and Medicaid eligibility. So it does all of this through some of the coverage expansion. Even though it does expand coverage to a lot more people, 10% more of us Americans, it leaves about 7% not covered. And largely that 7% is estimated to be undocumented illegal aliens here in this country, which are not eligible for any benefit under the Affordable Care Act. It defines essential benefits for health plans, which I'll go over a little bit later. It defines the commoditized products, or what we call metals, and I'll talk a little bit about the metals here a little bit later in the presentation. It prompts delivery integration, and it creates the accountable care organizations. It has demonstrations for bundling, for medical homes, and many other innovations that the Centers for Medicare and Medicaid Innovation are putting out now. It seeds the creation of provider-sponsored health plans through the creation of ACOs. And so you're starting to see developments of providers, mostly large tertiary providers, actually creating their own health plans. In other words, moving into sponsoring risk through the creation of these innovations through the Affordable Care Act. There's some cost management programs that are being administered by the Centers for Medicare and Medicaid Innovation. I know there in Michigan, you guys are participating, for example, in the Hospital Engagement Network, which is a program that CMMI is operating for hospitals to reduce harm to patients in 10 key areas of risk and ways in which hospitals can creatively manage the reduction of those risks and harms to patients. Promotes best practice clinical pathways through PCORI. PCORI is the Patient-Centered Outcomes Research Institute, and this is where research can be directed that's developed by patients on ideas that are interesting that could result in innovation through patient-centered research. And then last but not least, it has provisions for creating more not-for-profit health plans that actually provides loans to co-ops, which many of us in rural communities are familiar with cooperatives in terms of our agricultural products. So what's the public attitude towards the Affordable Care Act? So what is it that they like? They like dependent coverage to the age of 26. We've seen that. They also like the no lifetime maximum. This means that if you reach $1 million or whatever the threshold used to be on your policy, and you get to that point, then you are terminated in terms of being eligible for any further benefits. So this is something the public has been tested to like. So after 2014, January 1st, what will they probably like as part of the Affordable Care Act? Well, there's maybe going to be in many markets more choices of insurance products that are going to be available through the exchanges. There will be more transparency about cost and quality, which presents risk and reward, especially for providers. The essential benefits list. They'll probably like a guaranteed set of benefits that's going to be consistent across all plans. Guaranteed issue, no pre-existing exclusions. We know that many people like this. Certainly as you move to be older in the risk pool and you start to accrue as through the process of age more pre-existing conditions, this could be very good for that older group of folks that haven't reached Medicare age yet. The modified community rating, and the bill provides for that the oldest in the group, in the rating group, pays no more than 3 times the youngest. So if you're an older person in your 50s or early 60s, generally you'll come out very well under this program. Adjustments permitted for rating area, family size, and smoking. So basically, those are the 3 bands of risk that the Affordable Care Act allows for in terms of individuals being rated. So the only thing that will change your policy is the area you're in, which is your geographic area, typically the state, the size of the family that you're insuring, and the 3rd risk band is whether you smoke or don't smoke. And then there are significant subsidies the public will like for those making less than 400% of the federal poverty level, and I'll show a slide on that in a little bit. And then expanded Medicaid, and some states are, right now 26 states will be expanding their Medicaid populations to 138% of the poverty level. So here's a list of the essential health benefits that are provided for under the Affordable Care Act. So any insurance now after January 1st being offered, whether it be an employer-based plan, whether it be a plan based on the exchanges, whether it be at any other non-marketplace exchange product, has to have these essential elements as part of the coverage. So I'll let you look at the list. I'm not going to go over every one individually, but I will highlight one that I think is going to be very helpful is the mental health and substance abuse care. This is, you've seen some regulations. In fact, the government has released on this just yesterday on how the government's going to implement mental health parity. And I think that you'll see perhaps availability of dollars now following those that are insured, and this will include rural communities to expand perhaps some of their mental health and substance abuse care, which is very meager at best in many of our rural communities around the United States. So what will the public not like about the Affordable Care Act? I think there's going to be quite a bit, and you've probably seen a lot in the news about this, and I want to be completely honest with everyone that there was there's some downsides to what's happening with the law starting in January 1st. And it doesn't take a genius to know the operational problems with the exchanges. The website, healthcare.gov, went through a very miserable opening on October 1st. And we see that the process is being worked out, and the Secretary of Health and Human Services, as well as the President, have committed that the exchange, that the healthcare.gov website will be up and running very quickly. The individual mandate with increasing penalties, part of the issue of making sure that we can community rate, we have to have everyone in the pool. And so this mandate is supposed to be an incentive to create the need for people to get insurance. In some states, there may be a loss of choice, meaning that there may be only one or two issuers of insurance on the exchanges. And so you may not have, if you're down in Alabama, for example, you may only have one or maybe two choices to make in terms of insurance coverage from an insurance company. Loss of individual coverage if less than the essential benefit. And you're seeing a lot of distress now in the public with folks that are getting issuance of non-coverage from individual insurance companies, because basically the policies that they have currently do not meet the January 1st requirements of those essential list of benefits. And so you're hearing lots of people whose termination of coverage is being sent out, and they're being told that they either have to buy a product on the exchange or they have to go to their individual insurance companies and buy a policy that covers the essential benefits that I listed just a second ago. There could be an extensive amount of loss of employment-based coverage. There's many employers that are looking now at ways in which they could decrease their coverage of cost of employee insurance, and so they may terminate their employee-based insurance programs in order to place their employees onto the private exchanges. The modified community rating is something that the public may not like, because if you're younger, you may pay more. I told you a second ago that the law requires that the oldest pays no more than 3 times the youngest. Well, if you're 28, 29, 30 years old, it could be that you would be paying more for an individual product than you could go on the more open market to buy under the old system. Something very concerning to rural providers is what we're calling narrow, skinny networks, meaning that in order to extract better value on pricing for premiums, insurance companies may contract with fewer providers and driving more volume to those providers in order to justify lower costs of payment on reimbursement to providers. So this could be a real issue going forward if rural providers are excluded from networks, and this forces rural community beneficiaries to go to urban facilities or larger facilities as part of the skinny networks that these insurance companies are putting together. Better providers increasingly opting out. You could see the generation down the road of 2-tier delivery systems. Operational problems with employer reporting. Now, this requirement was deferred to 2015 by regulatory action, and this is basically the employer mandate. And there's been a lot of controversy over that because the law required that to start January 1st of 2014, and the administration has deferred that to 2015 now. There are hidden taxes in the law, and they're called hidden because they're not largely seen. It's not like a broad-based income tax. But this could be as much as 6 to 8% in some cases. So there's a medical device tax now. There's health insurance taxes. There's reinsurance taxes provided for, payroll tax, then exchange administration tax, and then the last but not least is the Cadillac tax. Now, some of these increased taxes may be offset by lower premium costs. So in the final analysis, overall, you may be paying less because your premiums for your insurance is less, but it could create a concern by some people on the hidden taxes. So what is the largest impact that the ACA may provide, and that is consumer empowerment. The key drivers of this are these exchanges will be creating the marketplace so that competition will exist between insurance products, and that insurance competition will then drive down prices is the way that this is supposed to work. One of the elements of this is empowering the consumer to make the choice between providers of insurance. The other ways in which consumer empowerment will be maintained is through product commoditization. This will be the metals, and I'll talk about a little bit that in a second. Last but not least are subsidies. And many individuals that are poor and low middle class will be able to purchase insurance through the individual exchanges, which may prompt actually termination of employment-based coverage for some of these groups. There's an increased cost sharing. This is a little bit contrary, I think, to what many of us might have thought originally when the law was passed. There will be more cost sharing in the future for products sold on the marketplaces and in group plans. Providers will need to pay close attention to payer mix and to credit and collection, maybe even more so in the past, especially if payments from insurance companies have decreased due to competition among the plans. I will point out to you in support of this notion that the Commonwealth choice in Massachusetts, in the Insurance Connector Authority, when they put out their product in August 2011 and asked consumers to choose among the various plans, the various metals, gold, silver, bronze, and then the young adult plan, when they asked them to choose which one, the competition between the plans became not only between insurance companies, but also you'll see that the largest selected product was the bronze plan, which provides for the lowest amount of coverage in terms of coinsurances and deductibles. And I'll talk a little bit about that in a second. So if you have a marketplace and your community is choosing plans on the exchange, and the bronze plan is the cheapest priced product, it's very likely that you're going to see more and more people signing up for those bronze plans, which includes a lot more higher coinsurance and deductible. In point of fact, on the exchanges, you will see the metals that are listed. First is the bronze plan, that's 60% coverage. And those are typically what we also call high deductible health plans, or the bronze level coverage. Silver is 70% coverage, gold is 80%, and platinum is 90% of the metal. So the implications there for providers going forward is the demand for price, transparency, and advantages will be flowing to those able to produce bundled pricing in their products. Increased provider discrimination among patients based on credit risk, so some of the better providers could be more selective about the patients they choose. Revenue cycle management has been and still will be a provider core competency even under the Affordable Care Act. There will be more cost shifting to those able to pay where possible. And so providers will be forced in terms of getting their total compensation into basically trying to collect more from patients as part of the process of treatment. Quality information will be required, and high-quality providers able to discriminate based on a patient's ability to pay. And this may, in fact, become more evident going forward in the future, and this will present problems for rural providers, largely being safety net providers will be having to treat patients that may not be able to pay the complete part of their bill. So these skinny, lower-priced networks. Market research and Medicare Advantage has said that price sensitivity is the key driver in marketplace selection of insurance products. Brand, network composition, and service are less important, and this will prompt plans to create skinny networks comprised of lower-cost providers. Unfortunately, many of our rural providers aren't necessarily always the lowest-cost providers, and so this will create a tension in terms of networks of insurance companies, including rural providers, in terms of participation in these networks. This could spell real trouble for rural providers going forward. And I think that this is something that NRHA is going to be watching very closely as these plans roll out and trying to understand just who's being excluded from being able to participate in these skinnier networks. I talked about Medicaid expansion. Medicaid expansion has been as another major part of the Affordable Care Act, that states that have chosen to will expand their eligibility up to 138% of the federal poverty level. The federal government will pay 100% of the expansion for the first 3 years. That's FY 2014, 15, and 16, and then phase down to 90% of the cost of newly covered recipients by 2020. Much of the conversation from states that have chosen not to expand Medicaid has been two things. One, the cost of that 10% cost share starting in FY 2017. And then no guarantee about what would happen after 2020 if, because this is all that the funding includes of this 90% level, and who would be paying after 2020. We'll obviously have a new president, we'll have a new Congress, and whether that would be maintained is an open question. 26 states have now agreed to expand their Medicaid roles in accordance with the Affordable Care Act. Most of those are along the New England, upper Midwest, and West Coast. A lot of the interior and southern parts of the United States have opted not to expand Medicaid. States still have the option to expand Medicaid whenever they see fit. However, the 3-year 100% coverage by the federal government is time limited to those first 3 fiscal years. So if a state decides to enter the Medicaid expansion in, say, FY 2016, they would only get 2 years of 100% coverage, not 3. By statute, the federal government will only cover, as I said, those years that I just noted. There have been significant challenges, again, with the federal marketplace, and now I'm moving to the exchanges. This has been fraught with difficulty in terms of healthcare.gov. Congress and administration are now looking at ways that this can be rectified. They're hurrying up to get these exchanges working in time. They're hoping by after Thanksgiving or the end of November to have this all up and running. If you don't see the exchanges up and running in a good form and fashion by the end of November, you'll see efforts to delay the implementation possibly of the individual mandate, possibly delaying that to 2015, just like the employer-based employer mandate. So in the exchanges, one of the things we're going to be looking at in order to this model to work is how much competition there is by state for the individual market. In other words, how many issuers of insurance are there in states that are operating exchanges? This basically goes to how you are actually able to compete with the plans in the market. So if you look at Michigan in this particular map, it looks like that you guys in Michigan have 10+ insurers in the marketplace. So that's that's quite a few actually. So Michigan looks like that the consumers in your state will have adequate choices among plans, insurance plans, to be able to make this program work. You can see other states. Let's go to Alabama, for example. They have 1 to 3 issuers of insurance there, and as I understand it, Alabama has only 1 product on the exchange for people to choose from. So that is going to be a significantly different situation than, say, California, Texas, Michigan, et cetera. The overview of exchange competition. This is a state-by-state listing of the different elements of what is being offered on the exchange. And it appears as though that, let's see, I had this identified yesterday, but I'm not catching Michigan exactly, but if you look down the list, you could pick it out. But this is the listing of the number of issuers or carriers on the individual exchange market, the number of carriers. This is the Small Business Healthcare Options Program, or the SHOP program. The SHOP program is an interesting program within the Affordable Care Act. It's available for groups of less than 50. So if you're in a small business, say with 25 employees, you can go to this Small Business Health Options Program, and you can go onto the marketplace essentially and buy coverage for your group. This is, again, supposed to be a method that will decrease cost. Oh, I found you guys, Michigan have 9 issuers in Michigan, it looks like. I just saw that on this graph. So I mentioned the exchange cost-sharing subsidies. So I think it's interesting to give everyone a glimpse of what the subsidies are on the exchanges for individuals at various levels of federal poverty level. So the 100 to 150% of federal poverty level. So if you're a family of, say, if you have one person in your household, that's roughly about $12,000, $13,000, as I understand it. So if you are within that 100 to 150% of federal poverty level, you will get 94% of your premium covered. So your charge to the employee, your charge to the the person covered is only 6%. So this is where the affordable side of the Affordable Care Act comes in, is through the subsidies that are being offered by the federal government to buy insurance for those in these various categories of listing. Interestingly enough, if you are 250 to 400% of federal poverty level, which for a family of 4, I understand, is close to $80,000, you would get 70% of your insurance premium covered as a subsidy under this exchange system. Now, part of the rub has been that if you are over 400% of federal poverty level and you have to go to the exchange to buy a product with no subsidy, that sometimes the premiums are coming out more than what you would buy on an individual market. There's been cases of that. We don't know yet how widespread or how significant that will be. So real concerns that we have on the exchange with different products. I will let you know that the law, the Affordable Care Act, provides for what's called the Essential Community Provider, or ECP. And this is essentially, and I'll go to the next slide, every qualified health plan, or QHP, these are the issuers on the exchange. So each qualified health plan, in order to be listed on the exchange, you have to be qualified, thus the term qualified health plan. One of the requirements of the law is that every qualified health plan has to provide for network adequacy and ECP, Essential Community Provider Sufficiency. I quoted that out of the law itself. So at some point in time, the government is going to have to make a decision about whether or not what's the definition of network adequacy and Essential Community Provider Sufficiency. Now, that's going to be interesting because right now, all critical access hospitals, so the definition of essential community providers, are 340B eligible. So this 340B eligibility notion is what we're working with now in terms of providers. So if you're a critical access hospital or a federally qualified health center in a rural community, you are considered 340B eligible. And those are automatically essential community providers. Now, we're very concerned because rural health clinics are not currently on the essential, is not an essential community provider. We don't know to what extent we have the possibility of getting them added, but in terms of the rural fabric in these skinny networks I talked about a second ago, we need to make sure that we understand what network adequacy is, what ECP sufficiency is, and make sure that we're fighting for these inclusions of these providers in these skinny networks that might be developing going forward. So You've heard a lot in the media lately about premium price increases and decreases. The problem with, you hear anecdotal stories about someone who went out to the marketplace and they went online and their premium for the product on the marketplace is twice as much as what they were able to get as an individual. I'm afraid that's totally possible, but it's always difficult to compare premiums pre and post Affordable Care Act. The premium spread among plans is significant. Consumers will choose usually the lowest price product, not the average price. So even in the individual market, going back to the current system, maybe they may choose the lowest price product, which doesn't cover nearly as much in their individual coverage. Complying with the essential benefit mandate represents a cost increase due to expansion of benefits. I mean, that makes sense if you're covering more. And so the premium cost increased for the young and healthy, and they decrease generally for the old and sick. And these increases are due to guaranteed issue, no pre-existing conditions, and maximum of 3 rate bands. There are hidden taxes and fees, and those at $0 and $100 premium will likely choose the bronze and silver plan. So this will have an impact on providers and their credit and collections efforts. It could impact their bad debt and charity expenses going forward. And in the very short time I have left, I wanted to just say that the Affordable Care Act provides for a lot of benefits to rural communities. It's more than just Medicaid and the individual mandate, in other words. It increased National Health Service Corps funding slots. It provided for residency reallocation to rural training tracks. Big provision of the Affordable Care Act was expanding the 340B program for critical access hospitals and sole community hospitals so that CAHs can now have the 340B program in their facilities. Community health center funding, it created the accountable care organizations under the Medicare Shared Savings Program, increased AHEC funding authorization, establishment of the rural physician training grants, establishment of Centers for Medicare and Medicaid Innovation, pharmacy reimbursement increases. It set primary care incentive payments. It basically made a floor for the hospital wage index for frontier states. It provided for community-based transformation grants. One of the things that we're working now is the extenders. This is a big problem for Medicare-dependent hospitals and low-volume hospitals. Modification of the low-volume hospital adjustment, it expanded really those hospitals that are eligible for low-volume adjustments or LVA, and then payment increases for hospitals in counties with lowest Medicare spending. The low-volume hospital program and the Medicare-dependent hospital program, you have both of those in Michigan. Those programs expired on September 30th of this year, which we're very concerned about, and we are working diligently to try and get those programs reinstated. For some hospitals, the low-volume hospital program was amounting to, $500,000 or more in reimbursement to these in-between hospitals located in rural communities. So what's the future of the Affordable Care Act? Well, politically, it will be very hard to repeal at this point. Even if the Republicans win a majority in the Senate and the White House and maintain a majority in the House through 2016, the Affordable Care Act's provisions will already be pervasive throughout the nation's delivery system. So it'd be like trying to unwind something that's already infiltrated pretty much every part of the healthcare system that we know, and to repeal it would be very difficult. We think that there will be some tweaking likely in the future. A member of both parties will want to fix some of the things that are contained in there. We've heard bipartisan support for repealing the medical device tax, technical components of grant and pilot programs, trying to deal with some of the technical issues of the exchanges and Medicaid. There could be some bipartisan agreement going forward. I wanted to close with just saying that rural is different, and the quality measures we rank are on par or better than urban facilities on CMS process of care, CMS outcomes, HCAHPS, which is the patient satisfaction, and then we do better on price and cost efficiency measures than on our urban hospitals. One of the distinctive features and why rural community hospitals, at least, are so important to the community is because of our emergency department. The total wait time in a rural ED is half as long as the wait time in an urban emergency department. The wait time to see a physician in a rural emergency department is 2.5 times less than in urban. And then it's more than 50% of all emergency department visits to CAHs, to critical access hospital, were categorized as low acuity. This is incredibly important because not only is the emergency room of value to those that have true emergencies, but it's a source of primary care in most of our rural communities around the United States. If it wasn't for the emergency room seeing primary care visits, meaning non-acute visits, then it would only serve to exacerbate the shortage of physicians in our rural communities and access points. We know that it's not an efficient place to provide care, but if it's the only place, we don't want to decimate this program while not having something to replace it. And then finally, rural care is 3.7% lower than the average cost per urban beneficiary. So not only do we have high quality, not only our emergency rooms are extreme value, but we're 3.7% less spend on a Medicare patient Medicare cost per beneficiary, which means that rural providers are doing a great job efficiently taking care of patients. And this is translating into saving. If urban environments spent at the same rate as rural, you would save $9.4 billion per year. Over 10 years, that's close to $100 billion. My theory is that rural is that rural is the answer to some of our cost problems by replicating some of the things that we're doing rather than decimating rural care by destroying some of our programs and services. We're also critical to the rural economy, and many of you who work and live in rural know that it's often the largest and fastest growing segment of the rural economy. Just an example, every rural physician that you recruit to a community has a spin-off effect of 23 jobs in the local area. Healthcare often represents 20% of a rural community's employment and income. So this is not only just it's not only value of providing services close to home, access to primary care, it's also an important part of your local economies, and we need to keep this going, if nothing else, just for that. Finally, I've listed some tools that are available to you if you have questions. These are some places: our website, ruralhealthweb.org, health reform at the Kaiser Family Foundation. I'd encourage you to check that out. And then it's improving, but you can send people to healthcare.gov, and they can sign up for insurance, if not now, hopefully soon. And then last but not least, the Office of Rural Health Policy, which is part of HRSA at the federal government, has an email address, and I listed it here, that if you have a question about the Affordable Care Act, anything, it could be something you've heard, something you saw, something somebody told you on the street, you're welcome to email them, and Deepti at Office of Rural Health Policy will answer the question and provide you resources in being able to deal with it. So with that, I'm going to stop now, Jessica, and see if there are any questions. If not, then I'll just turn it back over to you.
Hey, Brock, it's John. Thanks for agreeing to present. Just going back to your slide on health plans, we have anywhere between 12 and 14 regions.
So that's this one here?
That one, yes. So it's accurate. We have anywhere between 10 and 14.
Oh, wow. Okay, good. What's been your experience in rural providers being entered into the network with those plans being offered on the exchange?
Don't have one yet. Too new to really get any feedback.
Well, that's a real concern, as I said, going forward, and I'm so glad that you're keeping track on that, and certainly share with us any information you get on exclusions, because we need to get that definition of network adequacy and ECP sufficiency, and I don't know that HRSA has been working on that yet.
I agree.
Great, thanks, John. Does anyone else have anything, just rural healthcare in general question that you'd like to ask? Okay, well, thank you so much, Brock. We really appreciate it.
Okay, well, thank you guys very much for the invitation, and have a good afternoon.